And she
You want to put your slip out?
Yeah. You're nominating someone else. Oh, she's.
Yeah.
Okay.
What letter?
Yeah,
She just said.
I'm a feeler.
Her to talk about.
Yeah. Does she? What does she do?
Because I support Dr. Kaiser on one of his HIV projects.
Great. And Cheryl, I'm going to divide my case manager. So we work over together. Okay. And HIV part of my tasks is to make sure they all get their pap smears and mammograms. That's a fun one.
like her to pass.
It's
I had once and I didn't really get it.
that was good. I'm able to run like yeah, definitely. I'm spending a lot of time around the program and I'm
Okay, great.
How about you? Oh, do you have any teaching in school?
I'm Stephanie. I'm also an actor.
Yeah,
It's fine. Yeah.
Do you have your mic on?
Oh, they were going to bring it. I think he was going to bring it to me.
Oh, yeah. I'm sure Brad told you that other sites across the
Yeah.
TVCJ,
Yeah.
CMC.
Okay, there.
Yep, perfect. Yeah, they're a little tough. Is that red? Flashing?
Yeah, we're muted.
Right
Yeah.
there. Wait.
No,
Is it that way?
No, you had
No?
it right. That way.
It is
It's
right?
just a little tough.
Okay.
Perfect.
All right.
And if you want to go ahead and unmute it, we'll tap this
Yeah, go
button.
Okay.
You're good to go.
All right. Great. Wonderful.
So it's a little past noon, so we'll go ahead and get started. It's a real privilege and pleasure for me to introduce Dr. Judy Levine to you. Dr. Levine, I first met her when she was teaching my wife. My wife went to Baylor College of Medicine, and Dr. Levine is a real leader in training in her current work and also in training new students and residents and fellows to be as engaged and passionate in matters of access to care and health for women especially, but women across the country, across the world actually. Dr. Levison has been involved in Malawi and a few other countries, and I think she's going to present some of their work that they've been doing across the country with women and HIV. It's really inspiring stuff. I've looked up to you for a long time. I'm glad that you can be here. Without further ado.
I look up to him too. It's wonderful to be here, and I realize this is the first time I've ever been at UTMB. Yes, it's long overdue. So just to give you a little background, I'm an obstetrician gynecologist, and I care for the pregnant women living with HIV in the Harris Health System, the county system in Houston. And we get referrals from both the private sector as well as from the county and all around. And we'll be talking today about women in HIV and reproductive decision-making and sexual health. I have no disclosures. And I hope by the end that you'll be able to identify who's responsible for preconception counseling, and we'll talk a little more about what I mean by that in your healthcare system. List controversies in the choice of specific antiretrovirals for women of reproductive age, and explain how you would approach a woman with HIV who wants to breastfeed. We'll talk a little about planning to get pregnant or not get pregnant, which is really part of the preconception counseling discussion. Strategies for safe conception among serodifferent couples, meaning one partner has HIV, the other partner does not. And where pre-exposure prophylaxis or PrEP fits in, and methods for prevention of perinatal HIV transmission, so mother to child. So first of all, whose responsibility is it to raise the issue of pregnancy planning? And this is something, I don't think, we certainly don't have a single right answer to this, but if you have women living with HIV, men living with HIV, is it their primary care HIV clinician? There are many reasons for me to say yes, though discussing pregnancy or the plans for pregnancy, just as right now, doesn't tend to be part of the script that most primary care HIV physicians have when they're seeing their routine women and men. So, you have a guy living with HIV. What's his partner status? Male or female. And you have men having sex with men who are interested in becoming fathers and having, and how are they going to negotiate that? And so unless you ask, these things sort of seem to just get brushed away unless a woman asks specifically. So is it the OBGYN? Is it the client? Is it the client's responsibility to have to ask? And what if we added to the primary care HIV script, what are your pregnancy plans? And to the clinicians who are listening, how often do you ask? And also remember that just because you asked a person once in 2015 doesn't mean that his or her answer is going to be the same in 2019. And so that it does mean asking more than once. And Sarah Finocchiaria Kessler actually looked at where does reproductive counseling happen? And in a study of 181 women, only 31% of the women reported a personalized discussion with their provider specific to childbearing plans. And of those who did have a discussion, most of them had been the ones to initiate the discussion, not the provider. Women are getting pregnant. In 1998, there was one study that looked at individuals living with HIV. And at that point, remember, we were just beginning to have a good set of antiretrovirals. So people were appropriately nervous about considering pregnancy, and it was under 30% of men and women desired pregnancy in the future. And then look, in 2011, another survey came up with 75% of women said that they were interested in a pregnancy. So clearly, women have gotten the word that having HIV is no longer a reason to avoid pregnancy. So what do the updated perinatal guidelines say? And so the perinatal guidelines are there's a document, if you go to, and you'll see the reference in several places on the slides, it's www.aidsinfo.nih.gov. There are guidelines for adults and adolescents, there are pediatric guidelines, and there are perinatal guidelines. And every year, these guidelines are updated based on the newest studies. And just true confession, I am on the panel, the perinatal panel, so I have some very positive bias toward the guidelines. But I think what's kind of cool is that they also, once you've looked through them once, each year when they're updated, they will highlight the changes. And so if you don't have to read the whole document all over again, but you can read the highlights to see. And they also have a page in the beginning saying these are the things that are new this year. So what the guidelines say is discuss childbearing intentions with all women of childbearing age on an ongoing basis throughout the course of their care. Provide information about effective and appropriate contraceptive methods to reduce the likelihood of unintended pregnancy. And HIV infection does not preclude the use of any contraceptive method, but you do need to be aware of some drug-drug interactions between the hormonal contraceptives and antiretroviral therapy. You don't need to memorize anything about which drugs. There's a lovely table that I refer to on a regular basis within the perinatal guidelines that tells you which drugs you need to avoid or which antiretrovirals perhaps will interact. So let's talk a little about preconception care for women and men living with HIV and for serodifferent couples. And you'll also hear it said as serodiscordant, but there's what's called people first language, and so people living with HIV said, serodiscordant, there was something kind of jarring about that, and that, so we've moved more towards serodifferent. And I also want to say, for those of you in the room, if you have questions you want to ask along the way, please feel free to do that. Or if there's anything that's not clear. So we're going to go through the logistics for the serodifferent couple who desires pregnancy. And I do imagine it as a toolbox. And the issues are slightly different when you have a woman with HIV, a man without, or a man with HIV and a woman without. So the three basic tools are, number one, treatment of the partner living with HIV as prevention. And this was first published in 2011. And what they showed was that when they initiated antiretroviral therapy earlier than was the standard for, at that time in several countries, there was a 96% reduction in HIV transmission. Up until that point, people were only being started on antiretrovirals if their CD4 count had dropped below a certain level. And so in the study, they said, no, let's start earlier, before people drop below that level. And this really was sort of an eye-opener to everyone. 96% reduction if you're taking medication. So that was number one. Two, condoms. When we're talking about trying to get pregnant, it would be condoms except during the peak fertility times. And there are ways for women to try to figure out when is the most fertile time of each month. And then now we also have PrEP since 2012, pre-exposure prophylaxis for the partner not living with HIV. And that's daily oral tenofovir emtricitabine, also known as Truvada. So this was the first breakthrough, which was the treatment as prevention. And then an extension of that is that a little over a year ago, CDC actually came out and said, U equals U. Undetectable equals untransmittable, meaning that if an individual living with HIV has a viral load that's undetectable, and in our system, it's less than 20 copies of virus per ml. I think they consider it just in general, because not all labs go down that low, less than 200 sort of internationally. You can't give HIV to a partner. And I just last week was at one of the main international HIV conferences that was held in Seattle. And there was a talk specifically on this, basically saying to all of us clinicians, I know you're still kind of nervous about actually saying that to patients, like U equals U. Because up till now, up till recently, it was, well, if you have an undetectable viral load, very low risk of giving it to anybody else. But you can actually say you won't. And so the lecture was really on giving us permission to say that. But caveat is that if you are the person living without HIV, your partner has HIV, how certain are you that he or she is taking their antiretroviral therapy every day? If you're watching them, you're living together, you see them take it every day, that's one thing. But, you know, if you're not, how much do you trust that they are? And how certain are you that the other person has an undetectable viral load? Are you going to the doctor's visits too, or just, what do you know? And so I think that's where there's still room for the other tools in the toolbox. Then there's PrEP, and so that's pre-exposure prophylaxis, also known as PrEPception, if it's used around conception. And it means that there's the awareness that the individual has or might have a partner living with HIV. And so if somebody feels I might be at risk, or I know I'm at some risk, then it might dawn on them to consider PrEP, but they actually also have to know that it exists. And I can think of one of my pregnant women who, in our, you'll hear a little more about some of the sessions that we hold with our women. One of our sessions was on PrEP, and she said, wait, say that again? You mean I didn't have to get HIV? She said, I knew my partner had HIV. I just assumed I was going to get it at one point or another. And you just watched her suddenly realize, had she known about PrEP, that she could have prevented it, even because she didn't have control over whether he was taking medication or not. And I just want to give credit for the drawing, which is this lovely sort of guardrail around a city with Truvada in the front. There is this past year was an art project in Houston, led by a community organizer and educator, and he had middle school students do paintings related to World AIDS Day. And I had the honor of going and seeing their awards dinner, and was just really taken by some of the artwork. And again, I want to say this is middle schoolers. So middle schoolers learning about PrEP, and I think that's a great place to start. So PrEP, it's been approved since 2012, and it's now 7 years later, and we still seem to be having some trouble getting the word out. What's involved? And I think sometimes the primary care providers who don't do HIV have been made quite nervous about this, because it's like, I don't quite know what to do. And the same thing also for the obstetricians who are general obstetricians, who a woman comes in saying, I have a partner with HIV, I don't have HIV, but I want to prevent it. And, what do I do? And so we do baseline screening to make sure the person doesn't already have HIV, include a viral load just to make sure they weren't infected just in the last week or so, basic sexually transmitted infection screening, including gonorrhea, chlamydia, syphilis, baseline renal function because the tenofovir can have some adverse effects on kidney, pregnancy test, hepatitis panel, and Hep B surface antibody. And the reason for the hepatitis panel and the Hep B surface antibody is tenofovir also can be used as a treatment for hepatitis B. And if you're just taking your PrEP for preconception reasons or for pre-exposure prophylaxis reasons, there are times in your life you may feel you're more at risk and you take it, and there are times where you feel, well, I'm not having sex with anybody who puts me at risk. I don't need to take it right now. And if you happen to have hepatitis B, that's not such a great idea because you may have suppressed your hepatitis B, and then you go off the PrEP and your hepatitis B flares. And so we say check for Hep B, and if you do not have immunity, get the vaccine. Renal function tests every 6 months, and the immunization. And then one other question that comes up is, well, what if a woman gets pregnant? In fact, we had a woman just in the past month or so, she'd been on PrEP, she got pregnant, and once she was pregnant, she stopped it because she didn't know, you don't take medicines you don't need while you're pregnant. And even her primary care HIV doc said, well, just wait till you get to Dr. Levison and talk to her about it because I'm not sure if you should go back on. But actually, we recommend, if you have some risk, to stay on during pregnancy and breastfeeding because women are at higher risk while they're pregnant, especially late in pregnancy and during breastfeeding, immediately postpartum, than when they're not pregnant. And so you may need the PrEP more during that time. And we've been using the same medication for women living with HIV, that's Truvada, and have not seen any signal of any bad outcomes. So we're not worried about women taking it in pregnancy. So just where did this come from? And just to give you a little idea about, like, how did they come to show that PrEP was worthwhile. The first study was done in 2010, called the IPREC study. And what they did was they had close to 2,500 men having sex with men in multiple continents. And they were either given oral tenofovir, and that's a part of Truvada, not the whole thing, or no tenofovir. And initially, they saw a 44% reduction. And then, but they were smart. Not only were they testing for HIV, but they tested for drug levels in all of the individuals. And they found that there were a lot of people who had been randomized to the arm to get the tenofovir, but they weren't taking it because there was no drug in their bloodstream. And so guess what? It doesn't work as well if that's the case. And so they found 77% reduction if over 90% adherence and over 85% reduction if there was detectable drug. So if you take it, it works really well. So then somebody came along and said, well, that's nice. That's men having sex with men. What about our heterosexual couples? So the Partners trial looked at heterosexual couples, almost 5,000. And they had the negative partner being treated with the tenofovir alone, the tenofovir and tricidabine, which is Truvada, the combo, or placebo. And they had a 67% reduction with the tenofovir, 75% with the combo, and 86 and 90% respectively reduction if there was detectable drug. So 86% with the tenofovir, 90% with the tenofovir and tricidabine, Truvada. So that's pretty amazing. So you can protect yourself over 90% if the negative partner is taking it. So what do we do with all this? So if we have a woman living with HIV, man who is not, number one, we want viral suppression. We would like that woman to ideally have an undetectable viral load for at least 3 to 6 months, both to protect her partner and to prevent transmission to her baby. She can use ovulation predictor kits, and I'll show you those in a moment, and do home insemination. I mean, that is one option, and let's go over that. So next time you're in the grocery store, next to the pregnancy test, look for the ovulation predictor kits. So these are urine tests women can do at home. And basically, one line is you're not ovulating, and 2 lines is you've just had an LH surge, which is a hormone surge that happens 24 to 48 hours prior to ovulation. Once you have the LH surge, you get a positive test. You can say to your partner, okay, sometime in the next 24, max 48 hours, we should try. And these replace the old basal body temperature charts, which really were not that helpful in prediction. And then, when the time's right, one option is to do home insemination with a partner's semen. So if he's kind of nervous about suddenly after using condoms for all these years, not using condoms is not so sure about that. He can ejaculate into a cup or a condom, put the semen into a syringe in the vagina, and that way, and then go back to using condoms. And that way, he is completely protected, has had no direct contact. And I have to say, though, with U equals U, this is falling further into the background. But there still are men who are just, after years of being told, oh, you have to use a condom, this is still an option. Then, and if a woman has HIV and a man doesn't, does he need to take PrEP? So, again, it really depends. So is her viral load undetectable? I mean, hopefully it is if she's trying to get pregnant, but, things happen. Is she consistently adherent to her antiretrovirals? And how anxious is he? And I think the anxiety thing needs to be addressed. So then, if we switch and we say the man has HIV and the woman does not, again, maximal viral suppression of the male, ideally for 3 to 6 months. They also can go with her using the ovulation predictor kit to find out when is the ideal time. One other option is PrEP for her. And in the past, before U equals U, some people used some fancy assisted reproductive technology, going to the fertility experts, and they did sperm washing and washed the HIV out. but they found that sometimes the sperm washing would reduce the activity of the sperm. And I think now with all the good information on viral suppression that there's no indication for that unless someone's having a fertility issue, but not for HIV reasons. So if the man has HIV and the woman does not, does she need to take PrEP? Well, if he has a consistently undetectable viral load, maybe not, but this direction, there's still a little bit of concern, and it may be a little more theoretical than anything else, that even if a man does have an undetectable viral load, they have sometimes detected HIV in the semen. It appears to be less active than usual HIV when it's undetectable in the bloodstream, but that has just raised some concerns. And we also know that women are more vulnerable to acquiring HIV from a man than vice versa. And some is just because with intercourse, there's some mild trauma to the vaginal mucosa, and you are depositing semen that sits there for a while. And if there's HIV in there, it's, again, the women are more likely to get HIV per sex act than the other way around. And so, again, it's a really individualized discussion as to what people are going to do. Though I think that some of the foundation for this goes back over 10 years when, before we had PrEP, one investigator looked at 62 different serodiscordant couples, and the partner living with HIV had been on antiretrovirals and had a viral load that was, at that time, they used less than 500 for 6 months. They did timed intercourse, just like having condomless intercourse once or twice a month in the middle of the month, and they had no transmission. So I think, putting all these pieces together, we can say that people can really get pregnant very safely. So I'm going to ask you a question. So say we have a 29-year-old. Gravida 2 means she's had 2 pregnancies. She's had P1. She's had 1 delivery. She's had 1 miscarriage. She comes in for preconception counseling. Her partner was diagnosed with HIV 6 months ago, and they had been planning to have another child. What questions do you want to ask them? So what do you want to know? How are you going to counsel them before you start? Is he on medication? Right. Is she on PrEP? Uh-huh. Is he virally suppressed? Yes. How long has he been virally suppressed? Got it. So, and has she been tested? I mean, if she's on PrEP, hopefully she's been tested beforehand. Is he on antiretrovirals? What's his viral load? If undetectable, since when? Do they usually use condoms or not? What does she know about PrEP? So I think you guys have nailed it. Good question. Are you exclusive? Very good point. Very good point. And again, my counseling is very different. I have some couples who say, if I say, do you use condoms? Oh, it's all the time. And others, no, never. And others, well, sometimes. And so you're going to counsel them a little bit differently. And just knowing all those pieces of information. So we're going to move on to antepartum care for women living with HIV. So now she's pregnant, the woman living with HIV. And this is also another, to me, game changer. This was a study of mother-baby pairs between 2001 and 2011. They looked at 2,600 mothers who started antiretroviral therapy prior to conception. So they were on antiretrovirals, they were suppressed. They continued throughout pregnancy, had undetectable viral loads at delivery. There was 0 transmission. 0. So way back before medications, it was 25% transmission. And we generally say, well, about 1% chance of transmission these days. But if you fall in this category, you don't have to worry about your baby being born with HIV. So that's a huge weight off the shoulders of many women. About a third of our women find out they have HIV during their pregnancy, so we can't put them quite into this box, but we'll start them as early as possible. So our goal prenatally is to suppress the viral load. And when women first come in, we draw CD4 count, viral load, and a genotype if they are not already on medication. And that's to find out whether their virus is resistant to any specific drugs. But we recommend starting the antiretroviral therapy immediately, and then once the genotype comes back, which usually takes 2 or 3 weeks, then if you need to make an adjustment, you can. And the genotype is relevant even for women who've never been on antiretrovirals, because occasionally a woman will acquire from a partner virus that has resistance. And so then here comes the question of, well, have we really taken care of this problem? Do I really need to be, talking to you about this? In 2006, there were 8,700 women living with HIV who delivered an infant, which was a 30% increase since 2000. And in 1991, if we go back, there were 1,650 babies born with HIV. Now, that's prior to antiretrovirals. By 2009, it was 151. By 2013, 69. And so some people would say, okay, well, we've taken care of it. Let's move on. But, and again, the painting is another one from the middle schoolers of don't pass it on. So I think the numbers may seem small, but they represent the tip of the iceberg. Because remember that if you do not, without diagnosis and treatment, during pregnancy and labor, 25% of women with HIV will deliver infants infected with HIV. And if we sort of back off, we're going to start seeing more of that. And so the 69, it's a small number, but also some of those women were just plain lucky. They were in the 75% that just plain didn't transmit, even though they didn't do things quite right. And we don't know who's who. And so that 69, I think, really represents a much larger number. So what do we do if somebody is what we call ART naive, meaning they haven't been on antiretrovirals prior? We'll start antiretrovirals as soon as the HIV is diagnosed. In the distant past, we waited till the end of the first trimester, and we no longer do that. And if someone comes late, and often, so now in Texas, we test early and third trimester. And we see a few women each year who were negative early in pregnancy and have seroconverted during the pregnancy. So they're tested maybe around 35 weeks, and the test comes back, and we receive them at maybe 36 weeks. So here we have someone who got infected during pregnancy, is not on antiretrovirals, and we have really till about 38 weeks to decide what's the safest way for her to deliver. She hasn't a viral load under 1,000. By 38 weeks, she can have a vaginal delivery because the risk of transmission during labor with that level of viral load is very low. But if she's over 1,000, we would recommend a C-section. So what will work fastest is the newest category of drugs, the integrase inhibitors. Raltegravir, dolutegravir are terrific, especially with high viral loads. And so if you start with, say, a viral load of 40,000, you will get a 1 to 2 log decrease, which means you'll go for the first week from 40,000, the next week down to 4,000. By the third week, you'll be under 400. And so usually I say, give me 2 to 3 weeks with any woman, and we can get her down. And the other drugs don't work quite as fast. We'll check viral loads every 2 to 4 weeks after we start therapy, monthly until it's undetectable, then every 2 to 3 months, and at 34 to 36 weeks, just to help us make sure that we're lined up right for hopefully a vaginal delivery. And that last one is important because sometimes we've seen somebody undetectable and then, 35 weeks, 3,000. Sweetheart, what happened? And tell me what's going on in your life, because something's clearly not going right. What can we do? Can we get you down in time to for you to have a vaginal delivery? And I think I'll mention here just choice of antiretroviral therapy prior to pregnancy and during pregnancy has become a little more controversial just in the last 6 months. Maybe a little more, maybe it's the last 10 months, because up until then, we basically said almost any medication a woman was on prior to pregnancy was fine. We weren't seeing any problems with birth defects. There had been some concerns with one of the older drugs, efavirenz, that those were now gone, and we were feeling really, we said to the primary care HIV docs, whatever you put her on, we'll keep her on as long as she's suppressed. And then they released a study from Botswana last spring, and it's a preliminary release of results, and they just felt they couldn't hold on to it until the end of the study. And it was looking at probably the darling drug. It's, everyone's favorite drug called dolutegravir. It's one of those integrase inhibitors. And what they found, in just, again, these are still preliminary, and the numbers are not high, that in the women who had conceived on things other than dolutegravir, there was a 0.1% risk of a neural tube defect, or 1 in 1,000. In the women who had conceived on a combination with dolutegravir, it was a 0.9%, and that was about 4 out of 426 women, risk of a neural tube defect. And this could be by accident, again, because of these small numbers, but that was 0.9%, so 9 per 1,000. And so they said, we have to at least tell people about this. And so across the country and across the world, primary care HIV docs have been in a tizzy for all women of reproductive potential. There are some countries that have banned dolutegravir in women from 15 to 50, which I think is going a little overboard. Others are looking at it, doing sort of an algorithm, first finding those women, finding out if they're on contraception, if they're on good long-acting contraception, saying, fine, you can take your dolutegravir. And others have just, we here have not really known quite what to do. And we will talk with women when they come in, if they're on it, are you thinking of getting pregnant or not? We just have some concern, but we don't know if a year from now we're going to be concerned about this at all. And so just to be aware that dolutegravir is right now just sort of up in the air. But if someone comes into us and they're newly diagnosed, once the neural tube forms, it's 6 weeks gestation. So once they're beyond 6 to 8 weeks, it's fine to put them on it. And there was no problem in this large study in Africa that with women who are already pregnant. It was just the periconception question. And again, I really want to emphasize question. The newest analysis that was presented last week was down to 6 per 1,000, and I think they're going to have the final one at the end of March. And it's probably going to land at 5 per 1,000, and then we're going to not know what to do. But just to be aware, there's a little bit of controversy. So, and if we have somebody who we're following during pregnancy and we're just not seeing the viral load coming down, the questions we need to ask are, is it resistance or adherence? And hopefully we have that genotype, or if we don't have it, we can check it now. And the adherence issue is big. And just saying to women, tell me what's going on. And, we don't ask, did you take your medications last week? We say, so how many doses did you miss last week? And basically the message is, you're human, I'm human. How many of any of us have finished a full 10-day course of any antibiotic? And, really, trying to work with women as to what it is. And I can think of one young woman who said, okay, I know I'm supposed to take it at 8 in the morning, and this is when we were giving twice-a-day regimens. These days I rarely give twice-a-day regimens, but I'm supposed to take it 8 in the morning and 8 at night. Well, 8 at night I'm still out with my friends. And 8 in the morning I'm still sleeping. And so, I'm missing a lot of doses. And I said to her, well, let me ask you this. If we went to midnight and noon, how would that work for you? Are you home by midnight? She said, oh, yeah, I usually come home between 11 and 12. Yeah, midnight would be good. And I said, are you usually awake by noon? Oh, yeah, I'm usually awake by noon. So I said, how about if we do 12 and 12? Oh, yeah, that would be way better. And so just getting down to the nitty-gritty of what are people's lifestyles and what do they understand and, can really make a difference. If we have someone late in pregnancy who's just not suppressing completely, we will often add an integrase inhibitor such as raltegravir or dolutegravir because it'll bring the viral load down fast. We'll consider directly observed therapy. And for us, that means hospitalizing someone. In Chicago, for example, they have extra funding, and they actually have workers who can go out and kind of like the TB outreach and do directly observed therapy. Some people are doing things with telemedicine to actually watch the person take the medication. So I think there's a lot of potential for that. In our case, I will say to women, things aren't going quite according to plan. We have 2 or 3 weeks left to get your viral load down. What would you think about going in the hospital? And when I raise the question, even to women who say, I've been taking my medication, I expect a lot of resistance, and most women will say, yeah, I think that might be a good idea. And I've been shocked at how many women say, yeah, let's do it. And you bring them in, and basically they're in the hospital to get 1 pill a day, and maybe 2. And after a week, they see their viral loads have come down, and we then can make a decision. And, some of them will say, I get it. I can do it now. and others who say, yeah, it might be better staying another week and till I deliver. And so we'll kind of work with them to figure out what works best. And then if someone has a viral load over 1,000 to 38 weeks, they do get scheduled for cesarean. And the important part is the scheduling, in that we're not talking about someone coming in labor and then doing a C-section. Once they're already in labor, we've lost part of at least part of the advantage of doing the C-section. Then in labor, IV AZT should be given to women with a viral load over 1,000. So this would generally be women who are going to get a C-section. But if someone comes in labor, they're 8 centimeters, you just find out they have HIV, you want to doing a C-section probably won't do much for them, but the IV AZT may, and can reduce the transmission from 25% to closer to 10%. Scheduled section, as I mentioned, but a scheduled cesarean solely for the prevention of HIV in a woman who is well suppressed is really not recommended. And there's still some countries around the world where sometimes they don't have viral loads as easily accessible. Some of them do, have still been continuing to do C-sections for women because of HIV, but we are no longer doing that. There had been question about rupture of membranes. Back a while it was ideally you wanted to deliver the woman or do a C-section before her bag of water had been broken for more than 4 hours. Now, again, we know it's all dependent on viral load, and if you have an undetectable viral load, it makes no difference how long your bag of water has been ruptured, and it's fine to break the bag of water during labor and not have to wait like we used to. And I think this is just, if there's nothing else anyone takes from this talk, I want you to know about the National Perinatal HIV Hotline. This comes out of University of California, San Francisco. It is a 24/7 hotline, and you get a real human being. There are 3 tiers of people. The first tier are, incredibly well educated. And it will then, but if there are any questions, they will bring it to the 2nd and 3rd tier. And they are there for the most basic questions as well as the questions where there is no single right answer. And it's just a really wonderful, wonderful service. And I think sometimes docs have been hesitant that people are going to think they're stupid asking certain questions. But, at 3 a.m., you get a newly diagnosed person with HIV in your labor and delivery unit, call. And also realize they're funded for the calls, so they love getting the calls. And, so I think it's just a terrific, terrific service. And if you Google National Perinatal HIV Hotline or clinician, it also comes up as Clinicians Consultation Center. They're great, and I also do some work with them. Then, postpartum care. So once upon a time, we sometimes, if women had a high CD4 count, we would say they could go off antiretroviral after delivery. Now we recommend that everyone stay on. Contraception. And this is, a chance where you still have a captive audience, and so a chance to get people linked to supportive services, transportation, postpartum care after the obstetric care, and we try to make sure that appointments are made for postpartum visits prior to women being discharged from the hospital. And I think I mentioned this earlier, just that this is more for the women who are not living with HIV, and just if they are with a partner living with HIV, that the risk of acquisition goes up significantly from not pregnant to late pregnancy to postpartum. Then in terms of infant prophylaxis, so the standard is baby gets AZT twice a day for 4 to 6 weeks. There's sort of a middle-level concern. When there's middle-level concern, some people have given AZT with 3 doses of nevirapine during the first 8 days of life. For the babies where there's really high risk, so this is the mom who walks in, has HIV, has not been on an antiretroviral throughout the pregnancy, pediatricians really need to be notified as soon as possible before the baby's born. And this is where there's been a move toward drawing blood on the baby as soon as it's born, looking for what's called HIV DNA PCR, but starting the baby on full therapy and until the results come back, which is usually 5 to 7 days later. And the idea behind this is that this is a baby who is at risk for what we call acute HIV. And if you start medication early in a child or an adult who's just been infected, you prevent the HIV from getting into what we call the reservoirs, the lymph tissue, the gut tissue, where HIV hides. And these are the cases you hear about where they're suppressed. Let's say they've been suppressed for a couple of years. They had been picked up really early. Somebody goes off medication, and it takes a few years till you start even seeing virus in their bloodstream. And there had been one baby that they thought was the Mississippi baby about 5 years ago. They thought was a cure, where that was the situation. Baby was known to be at high risk, was started on medication. At 18 months, got lost to care, and and then initially had no viral load, and then finally around age 4 started to have a viral load again. But the idea, just that you understand, that's why there's a move toward this. And again, the pediatricians often will call, and we encourage them to call the perinatal hotline, because often you don't know, like, how high risk is this? Is this someone who should get it, or is this baby who shouldn't? And so just to have someone else to call and talk to about it. And I will often, even with the hotline, they sometimes laugh at me, even though I work with them. Sometimes I'll call them just to say, I just need to talk to somebody else. I know there's no right answer to this question, but I just need a few more brains to bounce off of. So then, next controversy is infant feeding. So what do the perinatal guidelines say? Avoidance of breastfeeding has been and continues to be a standard, strong recommendation for women living with HIV in the United States because maternal antiretroviral therapy dramatically reduces but does not eliminate breast milk transmission, and safe infant feeding alternatives are readily available in the United States. And this is in contrast to most of the world. If you're living in a country that is not a high resource country like the U.S., they had tried, like 15, 20 years ago, had tried formula versus breast milk. And what was found was, of course, U.S., oh yeah, give formula to everyone. What they found is more babies were dying of diarrheal disease than getting infected with HIV or dying from HIV. And so in countries, if you didn't have safe water, you didn't always have formula available, formula could be extremely expensive, and maybe you couldn't afford it all the time, that in those situations, formula doesn't make so much sense. And I was sitting at a cafe in Gaborone, Botswana, and as I reached for some sugar, I saw there's little creamer packages, and on the creamer package, it said not for infant nutrition. And I realized that probably somebody had said, hey, white powder formula, white powder coffee creamer, that coffee creamer one's a lot cheaper than the formula one, and somebody had probably, had probably used that as for infant nutrition, and it didn't work out so well. And so another reason why, again, formula just wasn't making sense. And so what was found is that exclusive breastfeeding, the risk of transmission is low, and whereas transmission initially through breast milk before medication was about 16%, with mother taking antiretrovirals, it is down, and we were saying 1 to 5%, and then the most recent study came out about a year ago, said 0.3%, so 3 per thousand. In the first 6 months, 0.6%, or 6 per thousand in the first year. So 3 per thousand. It's not 0, but it's pretty low. And so in the rest of the world, exclusive breastfeeding is what's recommended. And exclusive as opposed to like using formula when you can, which intuitively you might think, oh, it's not getting quite as much breast milk. That before antiretrovirals was found to actually be a higher risk, and there are 2 theories. One is that the baby drinks formula. It's not completely physiologic, can irritate baby's gut a little bit, and then you chase it with HIV-infected breast milk, and the HIV gets into the baby's gut. The other theory has to do with the mother's breast, that if you're alternately breastfeeding and not, you have more engorgement. Where there's engorgement, there's inflammation. Where there's inflammation, there's HIV, and that there's more shedding of HIV in the breast milk. So because of that, the message has generally been exclusive breastfeeding. And, I mean, again, now with moms being on good antiretroviral therapy, the risk seems to be quite small. And the reason that I kind of got involved in all of this is that, okay, in the U.S., we can just say, we recommend formula because here, we can get it for you, WIC, whatever else. But my women have taught me a lot, and many of our women, and it's the largest group that has brought this to my attention are my African women. And if you're from Nigeria, if you're from Cameroon, if you're from Ethiopia, you have a handful who are going to go back home who are just here to have their babies. That's just a small handful. And okay, my pediatricians kind of got that and said, oh yeah, okay, that makes sense. They're going back home. They should be breastfeeding. But most of my women are part of the Nigerian community in Houston, or the Ethiopian community, or the Cameroonian community. These are pretty tight communities, and they chat. And the women are terrified of anyone finding out that they have HIV. We have a lot of stigma in the U.S., but in these communities, it is still extremely high. And if you are not breastfeeding, and your family and friends come on Sunday afternoon, and they see you with a bottle in hand, that is the equivalent of a red flag. I have HIV. And the women have been there. We've had a handful of women who just said, I cannot, this would destroy everything that I have in terms of social support and my child being stigmatized and all kinds of things. I have to breastfeed. And so we realized that we needed to work with our women, and they were going to do it anyway, and we would much rather they do it safely than go underground. And we would rather they know that we recommended exclusive breastfeeding over mixed. We wanted them to be coming regularly for having viral loads done, maybe a little more often than normally they would get postpartum. Normally it would be once every 6 months, but instead maybe come every couple months. Their pediatrician should know. Baby should be tested a little more often. And some pediatricians prefer to keep the babies on medication while breastfeeding, and there's no evidence to support this, but more of a comfort level. And so, as I mentioned, I work on the Perinatal Guidelines Committee, and about 5 years ago, I and a few of my colleagues were aware there's some women are going to breastfeed, and the guidelines always said we don't, basically, formula. And we, so a few of us broached to the guideline panel, I think we need to just acknowledge that there's some women who want to breastfeed. And for about 3 years, we had the following sentence. This was the foot in the door. Clinicians should be aware that women may face social, familial, and personal pressures to consider breastfeeding despite the U.S. recommendation. This may be particularly problematic for women from cultures where breastfeeding is important, as they may fear that formula feeding reveal their HIV status. And so we encouraged that this be discussed early in pregnancy. And then and also, I think just one other thing I'll mention, the one other postpartum issue is pre-chewing, that there have been a handful of cases where individuals with HIV had pre-chewed food just as a baby was teething. And so you have someone with periodontal disease, so bloody gums, chewing food and giving it to a child with bloody gums, and there again, a couple cases, so we recommend not pre-chewing. And it's interesting when we bring it up to women, just by the way, no pre-chewing, the range is from, oh, I would never do that, to, oh, I mean, everyone in my family does that. And so you really can't, just kind of have to know what fits with that particular family. So March of last year, Perinatal Guidelines Panel added a section on women living with HIV who desire to breastfeed. And so it's still not recommended, but if you're going to breastfeed, and it's about a few-page section on what are the things to do. And so maintaining a consistently undetectable viral load, exclusively breastfeeding, continuing antiretroviral therapy, continuing prophylaxis maybe, and like our pediatricians just would prefer to keep the baby on something until a month after weaning, checking viral loads and testing baby a little more frequently. So we explained this is not what we recommend, but if you're going to, we'll work with you. And we also have the women see the pediatric ID docs before they deliver to also discuss it. And we just got approval to do a retrospective chart review on our 6 or 8 women who have breastfed, and there are about 6 or 7 sites in the country who are joining us, and it's sort of come out from the underground. There were a couple sites where they weren't sure they could really say this out loud. They knew they had some women, but they did not talk about it in any professional capacity because it was sort of, they felt they would get in trouble. And so we're kind of bringing it out of the shadows. And then in terms of the baby, so the options are no prophylaxis beyond the 6 weeks of AZT, prophylaxis with usually nevirapine through 1 month after cessation. And then there are 3 cases that were just published from Canada where the pediatricians put the babies on full therapy, which is like 3 drugs, higher dosage than prophylaxis, until they had finished breastfeeding. Which I think there's no evidence to support this. I think this is a little more than we really want to be doing, but just to know they're doing a bunch of different things to deal with this. And it takes a team to work with this, so it's us working with the women, working with our pediatricians, and with the mom. And we thought we were doing such a good job talking with our PDID people and about all this, and then realized that at delivery, it's the general pediatricians who are catching our babies, and we haven't included them in the discussion, so they now have been included, and so everybody's kind of on board. So, does U equal U? Preconception? Yeah. During pregnancy, seems to protect the mom who is on ART pre-pregnancy, during pregnancy, has an undetectable load at delivery, and then postpartum there, gets a little dicier, and we can't say that U equals U for breastfeeding. Yes?
So U equals U, in fact, how does that
It's a good question. Yeah. 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 Give me your email contact, and let me get back to you on that. But it certainly would be protective. I mean, I don't know if it, right. And so just one last thing, just want to address the issues of retention and care after delivery. So women are pretty good coming prenatally, but around the country there's been about reported 40 to 60% loss of care after delivery. So some of the things that we're doing, what our program's doing in Houston is, number 1 is group prenatal care. And some of you may be familiar with Centering Pregnancy, which is really a brand name product, which is 10, and what it is 10 2-hour sessions per pregnancy, and I'll tell you a little more about it. So really, the challenges in terms of retention and care is, getting our women educated about HIV, so they're not feeling, just because once you have knowledge, you do have power. Letting go of some of the stigma and shame, feeling empowered, and then being able to move on with their life, with HIV being only a small piece of the pie, and staying in care after delivery. That's really sort of what we hope to see. And so the Centering Pregnancy model, when applied to us, we realized that centering has certain topics. They're pregnancy-related topics. We realized that in terms of our HIV education, we really didn't have a lot of uniformity in how we were approaching things. And the advantage of the 10 2-hour sessions, I now spend 20 hours with my women who are coming to centering. Before, it was, 10, 15-minute visits after waiting for God knows how long. The women know that we start at 12, we finish at 2, and they can really plan their days a little bit better. And what we realized when we first went, my nurse practitioner and I went to the first centering workshop to find out what is this, that they asked us, This was for just regular pregnancy. How many, like, what are the topics you would ideally address in a pregnancy? Oh, postpartum depression and domestic violence and nutrition and exercise, blah, 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 blah. And then they turned to us and said, how many of these things do all of you discuss with all women? And everyone looked at the floor. And then we realized we had a whole bunch of topics that we wanted to address with each of our women, but, you know, we'd get caught up in somebody who was now homeless, or we'd get caught up in something else, and we didn't really have a curriculum. So now, what we have is we address our specific topics and the experience of being diagnosed with HIV, which sometimes women talk about for the first time ever, disclosure to partners and how you decide who you tell, understanding what HIV is, how the medications work, the importance of adherence to medications, how long can a woman expect to live with HIV, which is now basically as long as she was meant to live, what's the risk of baby being born with HIV if the mom's taking medications, vaginal delivery, C-section, safe sex, safe conception, PrEP, the logistics of staying in care after delivery, baby testing after delivery. We have one of the primary care HIV docs come to one of our sessions, one of the PEDID people come to another session, and so they see these are nice people, they can talk to them, they can ask them questions. And these are some of the responses that we got from women. You never know what you'll learn when you come here. I love it. We now have a community. When I see the other women outside of centering, we all say hi to one another. I thought I knew most of it about HIV, but I learned some more. I'm so grateful to be treated as a normal person. The group gave me not only physical, but also emotional and spiritual support. When I first found out I had HIV, I was ready to, and she swiped her hand across her neck like I was ready to kill myself. Now I know that I can live and be there for my family and children. So that's one. And then the other thing we're doing in Houston is FEMERSH, which is it's statewide, though we focus a little more on Houston, and Galveston's included in that. It's adapted from a model that was called the Fetal and Infant Morbidity Review. It involves identifying babies born with syphilis or HIV and doing data abstraction from their charts and then having a maternal interview and finding out from the mom, have an extensive interview, and not in these words, but, you know, it's 2019, got a baby born with HIV, you know, what happened? And what were the barriers to care? And there we go. And then we identify the barriers and then come up with some action items. And there's a group called the CRT, or Case Review Team. There's about 30 physicians, nurses, social workers, case linkage workers, epidemiologists, mental health specialists, drug rehab, correction system people who come. And one of the things I'll just mention that's active right now is transportation. If a woman has Medicaid transportation, has a child at home, if she doesn't have child care at home, she cannot bring her child with her to a prenatal appointment. And similarly, postpartum, she has a postpartum appointment. She's 10 days postpartum. She just had a C-section. She has her baby with her. She can't bring her baby with Medicaid transportation unless the baby has its own appointment. It is right now, Sarah Davis, Republican from Houston Medical Center, and Mary Gonzalez from a Democrat from El Paso, each have bills in front of the legislature right now to try to change that. And that part of that came out of identifying this, and it's also because the maternal mortality review groups have identified transportation as an issue too. So just to know that, you know, we don't just stop at, oh, well, I guess it was transportation, but we really try to then take it. We go from the micro, from the woman, up to the macro and try to change. If it's law, we try to change law. So, yeah, so that's it. And we're also working with the correction system in terms of integrating better linkage to care after release. And especially there's some new initiatives in the county jail system and trying to make sure nobody is just given a phone number to call when they get out of jail, but there's a warm handoff. I want to acknowledge my village, and we have an amazingly dedicated team, nurses, social workers, docs who are dedicated to all of this. These are two of my women at the end of their 10 sessions of centering. Great, thanks. Any questions? Yeah.
Is there centering curriculum included?
Yeah. Mm-hmm. Mm-hmm.
What's the response from other
You know, and I think, yeah, I think they do find it believable. I think it's whether their partners find it believable. I have one couple who came last week, like 2 weeks ago, and they've used condoms religiously since he was diagnosed about 10 years ago, and now want to get pregnant. And even the idea of him taking that condom off, he has HIV, and of him taking the condom off like twice, and she's on PrEP. And the idea of taking off maybe for 2 days out of the month, he was terrified. I wrote down a homework assignment for him, and we'll see what happens. But he's terrified he would give HIV to her, and so I think it really depends. Yeah. Mm-hmm. So the centering itself is, and you can go to the Centering Health Institute, you can Google it, and they have a centering like a whole thing, and you can get certified and all kinds of things. We adapted it with their knowledge for HIV, and I just last week when I was at this conference, this HIV conference, found out that 2 other centers have adopted our curriculum, and it seems to be working for them, because we weren't sure it works for us. Like, if we put it on paper, does it work for you? And one in the Bronx, one in Philadelphia, they're really excited. And the centering people have been kind enough to put our curriculum on their website. There's a way to access it for the HIV piece. No, it's Centering Healthcare Institute, and it's under a subset of called Centering Counts. And I don't know, I actually just the other day tried to access it myself, and I couldn't, and so I just asked them. They said you have to go to, it's called Centering Counts, and I don't know if you have to register for it, but it's free for the HIV piece. The other thing is you have to register with them to get all their workbooks and things like that. You pay something to get their basic workbooks, but theirs is just without HIV, but ours is. Mm-hmm. And now they have it free on their website. Mm-hmm. Mm-hmm. Great. Yeah. No, our Texas Children's docs also work in that Harris Health. So one of the Texas Children's docs sees every one of our women in Harris Health before they leave the hospital, or if they happen to deliver Texas Children's, they'll deliver over there. They'll see them there. So they get 2 weeks, 2 months, 4 months. They're tested for HIV, and then they get one final check at 18 months. Okay, thanks.